I'm going to take care of all the expertise of Tomer first, and then we'll go on and get some expertise out of Dr. Furman. I'm Mort Coleman. I think you all know me, and to my left is Dr. Tomer Mark, one of our bright young faculty members in multiple myeloma. So since I got Tomer here, I'm going to put him to work. And Tomer, what I want to know is,
sir.
do you transplant all of your transplant-eligible myeloma patients on first go-round?
No, we don't. We follow more of the Northeast and Mayo model of usually collecting and waiting until first relapse to transplant. This is in direct opposition to sort of standard of care in the southeastern United States and northern New Jersey.
Right, which you transplant anything that walks. But what do you think the data are? Do you think there are some data to indicate that that transplantation enhances survival? There are other data that suggest that it doesn't matter when you transplant a patient. What data do you believe?
I believe it doesn't matter what the timing is, at least with the data we have. You know, there's a study published now, close to 20 years ago that said that timing of transplant doesn't matter, that the overall survival is equivalent whether you do it up front or at first relapse. However, there was a paper published in New England Journal of Medicine earlier this year by Antonio Palumbo that compared upfront transplant versus lenalidomide, melphalan, and prednisone that showed superiority for the transplant. When I asked other experts around what they thought of this data, what they said is, sure, transplant beats a inferior regimen.
What was his control arm?
The control arm was the lenalidomide, melphalan, prednisone. Continuous therapy.
Right, well, in using melphalan, which most of us would not use.
That's right.
With that in mind, what is your favorite first-line regimen for transplant-eligible patients on a patient who is off study?
I have to tip my hat to you, Dr. Coleman. My favorite first-line regimen is the BIRD.
Right, and what do you think is well, why don't you tell them what the BIRD is?
The BIRD is clarithromycin, also known as Biaxin. That's where the B comes from. Revlimid, lenalidomide, and dexamethasone, BIRD. And our data now goes out to 8 years and shows that at 8 years, approximately 65% of the patients are alive and well without progression. Which is a testament to the fact that giving continuous lenalidomide not only is it possible, but leads to excellent outcomes.
Do you see a whole lot of myelosuppression what dose do you use in maintenance, and do you have to reduce the dose of maintenance further out, and do you see any myelodysplasia, as has been reported after transplantation?
So we keep our patients on we start our patients on the full BIRD. Once they get to their maximum response, we will usually drop the Biaxin entirely and reduce the dose of the dexamethasone, but we will maintain them on full dose lenalidomide, 25 milligrams for 21 out of 28 days, as much as they can tolerate. We don't see significant cytopenias. In fact, the cumulative side effects of lenalidomide are not bone marrow toxicity, rather they're diarrhea and fatigue. You only see the secondary myelodysplasia or other secondary malignancies when you give the lenalidomide in close conjunction with an alkylating agent, like melphalan, for instance. And so when we have a patient who's taking BIRD induction and we transplant them, contrary to the CLGB and IFM studies, we don't start our lenalidomide maintenance at 3 months post-transplant. We start at 6 months post-transplant to allow for more bone marrow recovery.
So with that in mind, if you have a transplant patient, and in light of the fact that myelodysplasia has been reported at a greater incidence in patients who've received an alkylating agent for transplantation, high-dose melphalan, for instance, what would be your favorite maintenance regimen for a patient who has been transplanted? Would you use a proteasome inhibitor, or would you use an IMiD? Just what would you use for maintenance?
So I am parsimonious with my use of myeloma drugs, given that there's only 6 bullets in your gun. So if the patient has been induced with BIRD and had a good response, I will use lenalidomide maintenance. If I have induced a patient with Cyborg-D, which is cyclophosphamide, bortezomib, dexamethasone, we'll use bortezomib maintenance to, again, conserve agents. There's some emerging data right now out of Europe showing that if you have a deletion 17, post-transplant proteasome inhibitor maintenance may be superior, but that's early incipient data.
So you're trying to save the other drugs for a later time when you may need it. Is there any merit in using an alternate drug that might give you an even more profound response, such as we use with carfilzomib induction, and then we use IMiD maintenance? Is there any merit in using an alternative drug to get a deeper response of your proteins?
There may be. There's data mostly out of Europe showing that if you achieve a flow-negative state post-transplant, that is associated with very good long-term outcomes. For instance, if you are flow-negative post-transplant, have minimal residual disease that's negative post-transplant, the chances are 90% plus that you will still be minimal residual disease negative 5 years later. And carfilzomib induction in combination with lenalidomide and dexamethasone is associated with a very high rate of deep responses.
These responses. How do you define what we call a strict complete remission?
So a strict complete remission is we take the IMWG definition where in addition to have the normal criteria for complete remission, which is less than 5% plasma cells in the bone marrow, if you do immunohistochemistry in the bone marrow, there has to be lack of clonality, and the free light chain ratio has to be normal. This is one step below the recent IMWG update of immunophenotypic remission, which requires either a flow negative state or a negative PCR for the original clone.
So I gather you use the BIRD regimen for transplant eligible and transplant ineligible patients. Have you encountered any difficulty harvesting stem cells after using the IMiDs? There was some reports certainly early on that this was that it seemed to knock out some of the stem cells in terms of your ability to harvest.
We have shown that you can collect stem cells at any time, either using a cyclophosphamide mobilization, and that was published in 2007, or using plerixafor for mobilization. That was published by John DiPergio in 2010. So we've given actually up to 56 cycles of lenalidomide, have had no problem collecting adequate stem cells to support 2 transplants.
That's terrific. Is anyone in the audience, small though it may be, have any questions for Dr. Mark? Anything at all? Well, let's go over to Dr. Furman for a little while, and then we'll give you a chance to catch your breath, and I'll ask you some more questions since no one else.
I apologize for my tardiness.
That's okay. You were hungry. Tell me, Rick, how do you treat infirm or elderly patients? What do you use as your first-line therapy? Do you use chlorambucil with an antibody, a singling inhibitor, antibody alone, or BR, bendamustine, or rituximab?
So I believe the most important thing for all of our CLL patients, and it's important to recognize that I believe that it's important for both the fit and the unfit CLL patients to avoid chemotherapy. When you think about the tolerability of FCR, yes, a 50-year-old is going to do better than a 75-year-old, but we need to start thinking about that 50-year-old when he's 70 or they're 70, and all of a sudden they've had FCR 20 years ago, and whether or not they're still going to have functioning marrow, and whether or not we're going to see astronomically high rates of MDS. So Mitch Smith published out of the ECOG study looking at fludarabine versus fludarabine plus cyclophosphamide a rate of about 7% MDS AML at 5 years with the FC arm. And so it's important to recognize that those patients didn't receive second-line therapy. And, you know, obviously from our perspective, an MDS and AML diagnosis is a death knell. So I really believe for all patients avoiding chemotherapy is important, and I do believe that bendamustine is as likely to cause secondary myeloid neoplasia as is FCR. So my preference is always to start with one of the new kinase inhibitors, either ibrutinib or idelalisib, because those certainly have the ability to offer the most sustained response. And If I'm unable to obtain one of those for approval or insurance reasons, then I would actually go forward with obinutuzumab or ofatumumab. And I don't use chlorambucil because of my concerns with the effects of the chlorambucil on the marrow and the paucity of data that it really adds much to the obinutuzumab. It certainly may provide ostensibly a longer progression-free survival, but for our patients, really progression-free survival is a very short-term goal, and we really need to be thinking about much more long-term.
Okay, but let me ask you, do you think there's any benefit in the newer antibodies, ofatumumab or alemtuzumab, over rituximab? And when you look at the studies, they always use a great deal more of the protein than Rituxan is generally used. And we do know that if you increase the amount of Rituxan you give, that you get a better response. We reach sometime what we call the maximum financial dose rather than the maximum tolerable dose. So if you look at those studies, suppose you use the same amount of antibody, do you think you would get the same results, or do you think there's something special for GA101, which is otherwise known as alemtuzumab?
I do think that there is an advantage with obinutuzumab over rituximab. And I think that yes, Susan O'Brien did a study looking at rituximab at doses as high as 2,250 milligrams per meter squared. And certainly the response rates improved dramatically. But, when you do look at the obinutuzumab versus the rituximab, the doses are not that dissimilar. And I do think that, with the chlorambucil obinutuzumab study that led to its approval, we do see MRD negativity, and we do see very good responses. So I do think, and because of obinutuzumab's design, there's at least a scientific rationale for this difference. And so I do think that there is a benefit of obinutuzumab over the other antibodies.
Well, it is a type 2 antibody, which is different than rituximab, which is a type 1 antibody. The only other type 2 antibody that I know that has been used in the clinic is tosatumumab, which was used in a radioimmunoconjugate called Bexar. And interestingly, there are some patients who were heavily pretreated who received this treatment who remain free of disease at 15 years. They may represent one of the few instances of where you possibly may have cured a follicular lymphoma. But nevertheless, they did front-load that study.
We actually had a few patients on that study who received naked tosatumumab, who actually did excellent as well. So there's definitely some activity in the naked antibody. And given the fact that the antibody is a murine antibody and doesn't activate the immune effector cells through the FC portion of the antibody, we really are stuck relying upon the FAB prime, the CD20 ligation from the complement determining regions as the only mechanism of action. And so these amazing responses that we saw are probably indicative of truly what a type 2 antibody might be able to do. But I think the type 2 versus type 1 antibody designation is very artificial, and I'm not really a big fan of using it. I think that it's really a big to-do about nothing.
It may very well be. So if I understand you correctly, you're treating all your CLL patients, infirm and non-infirm, up front with a signaling inhibitor. Is that correct?
Yes.
What do you say to the individual who says, well, if you give FCR and you get a very good sustained remission, that there's a plateau of about 20 to 30% of patients who don't seem to require any therapy, although they may still have some of the disease. And whereas with the signaling inhibitors, you have to keep them on it continuously.
So that plateau is primarily comprised of mutated CLL patients. So once again, what we have found is that good patients do well. And so I'm not so convinced by the plateau on the curve that really is worthwhile. But I think ultimately, once again, what you have to look at is 7% of the patients had to die from MDS and AML in order to get that 30% plateau. And, it just seems to be, an unfortunate game to choose who's going to live and who's going to die based upon the toxicities when we have agents that, when you look up front at the ibrutinib study 1102, which looked at treatment-naive patients over the age of 65 who required therapy, we had 31 patients treated with ibrutinib, 2 stopped for patient choice, 2 stopped because of adverse events, and 1 discontinued at month 9 due to a Richter's transformation that likely pre-existed. And what we in essence find, though, of the remaining 26 patients, all of them remain free of progression at 40 months. So all of a sudden, we're already approaching we're halfway to that 10-year mark that FCR sort of boasts about. And, it'd be sort of interesting to see, whether or not we can replicate those figures.
Well, let me ask you the $64,000 question, which a lot of people have in mind. When you're choosing a signaling inhibitor, how do you go about choosing which one, idelalisib versus ibrutinib?
So ultimately, we haven't had a lot of time in order to formulate such opinions because idelalisib's only been approved since August. Currently, there's really not a great deal to discern which patient should use one versus the other beyond the drug-drug interactions that we see with ibrutinib and the potential increased bleeding risk that we see with ibrutinib as well.
So you select your drug based on the comorbidities the patient might have. So, for instance, if the patient is on Coumadin, you would select idelalisib, I would presume, or if the patient has some sort of cardiac disease and you're worried that they may develop atrial fibrillation, you would choose idelalisib. On the other hand, I'm asking you how you would approach this. If the patient has a history of pneumonias or has a history of diarrhea to begin with, I guess you would go ahead and select ibrutinib. So right now, your choice of which drug to use would be based on the comorbidities, you think?
Sure. I think really the Coumadin and the atrial fibrillation are really the only two that are primarily of concern. I think the thing that's important to keep in mind is that both ibrutinib and idelalisib have diarrhea. The diarrhea is actually different for both of them. One of them is a fulminant colitis that develops as a late-term side effect, and the other...
That's for idelalisib.
That's for idelalisib. And for ibrutinib, what we see is a grade 1 diarrhea occurring in about 50% of patients almost immediately.
And that can be controlled pretty easily with,
Yes.
With various antidiarrheal medicines. Most of the you get diarrhea also with idelalisib. It is true, though, that these explosive diarrheas that you're referring to generally tend to be fairly rare, I would guess. What percentage would you say?
So there's an important distinction where the diarrhea in the relapse refractory population tends to be a very late finding and occur in about 10%. But there is a different type of diarrhea that's not as severe that happens much more frequently in the less heavily treated and treatment-naive patients. And
Right.
so the late diarrhea is a true colitis that really requires steroids to control. The earlier diarrhea, which also has some inflammation in the colon when we look at it on biopsy, often responds to just stopping the drug, and it tends to be much more milder.
Oh, okay. And what kind of steroids do you use? Do you use systemic steroids, or do you use steroids, enteric steroids, if you would call them that?
So I primarily use systemic steroids just because of issues I've had with, when a patient develops a diarrhea that's very severe, often it's in wanting to act quickly and gets therapy started and get a quick response. I have transitioned patients over to budesonide, which is the enteric steroid, with no systemic absorption. And I know many investigators have actually continued patients on idelalisib with the continued dosing of budesonide to sort of control the diarrhea.
So right now you're saying it's 6 1/2 dozen of another, which one you would start with in a patient who has no comorbid problems. In other words, you could choose idelalisib or you could choose ibrutinib. The results seem to be very, very good. The response rates, particularly in non-heavily treated patients, the 80 to 90% level.
I think the true response rate for these agents is much higher. And I think one of the things that's important to recognize is that, our response criteria had to be adjusted. And, we certainly have removed lymphocytosis as a definition of progressive disease when you're using a B-cell receptor antagonist. But we didn't allow people to be responders until they still had that drop in their lymphocyte count below 50%. So we have a lot of patients who are stable disease who really are having amazing responses, and we have a lot of patients who are evolving their responses over time. So patients who go from stable disease to a PR at 18 months or from a PR to a CR at 3 years. And so I think that, this artificial decision as to when we look at the data is also a little bit problematic because it's not giving us the true benefit of the drug. And I think that, we have to see with time how really wonderful these drugs are.
Okay. Do you think that adding rituximab or adding bendamustine or bendamustine plus Rituxan adds anything to ibrutinib, idelalisib, or would we be just better off using them by themselves? Most of the data for idelalisib have been generated with rituximab. But do you think idelalisib would be just as well served to go without the rituximab? And what do you do? Do you use them singularly or do you use them in combination? How do you use them?
I use them singularly. I mean, I think the kinase inhibitors are doing the heavy lifting, and I think the chemotherapy or the rituximab is really responsible for most of the toxicities.
Oh, that's fascinating. Now, getting back to Dr. Mark, who I've given a break to.
Sorry, I have to wake up.
You'll have to wake up, Tomer. Now we have we have a second generation proteasome inhibitor and we have a third generation IMiD. When do you use them? And which one would you use first?
So we use them pretty much according to the label. So the label for carfilzomib is you must have progression of disease after prior bortezomib and a prior IMiD. And the label for pomalidomide is you must have had progression after prior lenalidomide and bortezomib. Now, for pomalidomide, this makes sense because people who are refractory to thalidomide will respond to lenalidomide. People who are refractory to lenalidomide tend to respond to pomalidomide, but it doesn't work the other way around. And so in my theory of parsimony for myeloma management, I will want to play the long game and save these agents for when the patients truly need them. Now, the story is a little bit different for carfilzomib, and it's been used in the frontline setting with absolutely fantastic results. But we don't know whether that will sort of derail other proteasome inhibitor therapy. We know that carfilzomib will work after bortezomib failure, but we don't know the converse.
Yeah, one of the problems we have is defining refractory and failure and relapse. There's a huge difference between a patient who relapses off therapy and a patient who has progression of disease on therapy. Are you convinced that pomalidomide, if you look at some of the data, they're not overwhelmingly impressive, although there are some responses in patients who have true refractory disease to Revlimid. In a situation like that, you probably would pick, I guess, carfilzomib if he looks at it, if it looked like he was truly resistant. And how do you define refractory?
So that's a complex question you just asked, multi-part question.
Right.
So I'll take the last part first. So the way we define refractory disease is progression on or within 60 days of last therapy. And by progression, we mean an absolute increase in the M protein by at least 0.5 gram per deciliter. When it comes down to small M proteins, pathologists eyeball what it is, and they sort of make a guess. So, when you have a patient come into your clinic and they're very upset that their M protein went from 0.4 to 0.6, that's really no cause for concern. As for whether your choice of agent should be carfilzomib or pomalidomide if somebody has failed lenalidomide, people have looked at that, and it makes no difference. You don't necessarily have to class switch when somebody has refractory or progressive disease to an agent, which isn't intuitive. We've also looked at the question in our clinic of what's better, carfilzomib first or pomalidomide first. And it also turns out that it makes no difference. The timing and the order should be based on patient comorbidities. For instance, if a patient has rip-roaring heart failure, you may not want to give carfilzomib. If a patient has a history of intolerance to lenalidomide, you may want to choose the carfilzomib first.
Okay, and would you address the carfilzomib issue in terms of congestive heart failure and dose? Do you think there's any relationship to the dose that's given?
I don't actually. So the FDA label dose is 20 milligrams per meter squared for the first cycle, followed by 27 milligrams per meter squared subsequently. Subsequent studies have looked up doses all the way up to 56 milligrams per meter squared. That's the dose that we give in our clinic. We now are beginning to learn more about the heart failure signal. It turns out that giving the carfilzomib as per label over 2 to 10 minutes intravenous infusion may be too fast, and we've switched to giving it over 30 minutes. There also was an excess of prehydration. People are very eager to hydrate their patients on carfilzomib because there was a fear of tumor lysis syndrome and subsequent renal insufficiency. So in our clinic and many others across the country, we're giving longer infusions and less hydration, and we have learned and we have much less of a heart failure signal.
And I fully concur. Now, we'll give you a break and let you go back to sleep, and we'll go back to Rick and ask him some questions about what is your treatment of choice for Waldenstrom's macroglobulinemia, first line.
So once again, my first line treatment for Waldenstrom's macroglobulinemia is the same as it is for CLL. I mean, the kinase inhibitors work amazingly well in Waldenstrom's as they do in CLL. And in fact, these agents really work across such a broad swath of, broad array of low-grade lymphomas that they really can be used in almost any of them.
So I'm hearing that you're using the signaling inhibitors before you use a monoclonal antibody. Is that correct?
Yes.
Would you care to comment on rituximab's impact on the myeloma spike initially with the flare? And
So it's interesting. When you look at the monoclonal antibodies, we have rituximab, we have ofatumumab, and now we have alemtuzumab. And there are no data for alemtuzumab in Waldenstrom's at this time. Rituximab generates the responses are very mixed. So in the published literature, there's about a 30 to 50% response rate. And some larger studies will show, some smaller studies will show higher response rates. I think, the response rates in Waldenstrom's with rituximab are very problematic because of this tumor flare. And that no one's done a proper study which is try to discern if you ride out the tumor flare, how does the patient do? And obviously I'm not talking about letting a patient suffer, but if someone's IgM goes from 3,000 to 6,000 and they're not having any problems with that 6,000, there's no problem with watching, and often you'll see it fall. So I don't think we know truly what the real benefit of Rituxan is for these patients. I think it's also problematic, though, because it can be very dangerous to treat a patient with rituximab who's got a high IgM spike.
yeah, that's true. But you will see, you can sometimes plasmapheresis them, and then you will see that the impact of the Rituxan really lasts for a long period, and that over months the protein will continue to fall.
So data that we generated using ofatumumab at a dose of actually just 2,000 milligrams, 300 milligrams times 1 followed by 2,000 times 4, really actually generated very nice response rates of about 70 to 80% with no tumor flare. And so I really think that, there are certain advantages. And the theory behind the ofatumumab was based upon its use as a complement activator, which might have a better role in preventing this tumor flare, which is theoretically induced by differentiation of the lymphocytes when CD20 is ligated. So we have seen that. I mean, of course, we don't have the correlative sciences to back up that theory, but we certainly have the clinical data to support that.
Well, talking about flare, let's talk about the role of IMiDs in the treatment of chronic lymphatic leukemia. Where do you think they should fit in your schema of treatments, and what do you think about the flare that you can sometimes see with the IMiDs?
So it's a very important. So I think IMiDs are very effective for treatment of CLL, but I think because of their side effects, they certainly take a backseat to the kinase inhibitors. I think a very important distinction between the kinase inhibitors and the IMiDs is the differences between sort of the BCR antagonist-induced lymphocytosis, which is associated with tremendous reduction in lymphadenopathy in association with patients feeling great with the rise in the white count, versus what we see with the IMiDs, where patients have a rise in the white count, usually develop tender, painful lymphadenopathy, and often have fevers and just feel awful. Now, the tumor flare is often, herald a response, but it certainly is a difficult thing to get the patients through that. I think that if I were to envision a way to use lenalidomide long term, it might be sort of as a maintenance therapy, post-induction to try to really preserve a remission long term. But I think, with our new agents, that the role of the IMiDs is much less important now.
There's been a little bit of controversy that when you get the flare with the IMiDs, whether you should or should not use an anti-inflammatory agent, because some people contend the inflammatory response has therapeutic efficacy. Would you use steroids in that instance?
I do, because the thought process behind not using steroids for an IMiD-induced tumor flare is really just theoretical. And the patients are very symptomatic and really require treatment. And, even when the patients do get steroids, we do see a benefit. And in fact, I do think the IMiDs make the CLL more sensitive to the steroids anyway, so there might be an anti-leukemic effect as well. So I do use steroids.
Okay, and the other issue that comes up is, how would you sequence the IMiDs? Would you sequence them in before chemotherapy if you found a patient was resistant to a Brutonib or a
Well, that's
or would you go to the other signaling inhibitor? How would you sequence these particular new drugs that we have available for CLL?
Well, that's a sort of a moot question, because I would give the patient sunlight before I give them chemotherapy.
I understand you have an aversion to it. So you have a patient who has a Brutonib resistance. It does occur. We in fact, you have been in the forefront of demonstrating resistance to a Brutonib and the mechanisms. So you get a patient, they're rare, but they do occur, who's a Brutonib resistant. What do you do next?
So my next choice therapies would include something along the lines of high-dose methylprednisolone, that's an important regimen to keep in mind, because most of these patients who develop ibrutinib resistance or idelalisib resistance are going to have a 17p deletion. And we know that high-dose methylprednisolone works regardless of p53 status. But so it would be a high-dose methylprednisolone, or it would be another kinase inhibitor like idelalisib or ABT199 on trial.
If it were on the market.
Right.
So where would IMiDs come into this particular schema? And what about IMiDs' impact on patients who have chromosome 17 abnormalities?
So IMiDs, patients with 17p deletions do respond to IMiDs. I've markedly reduced my use of IMiDs since the advent of these kinase inhibitors. So it's really a situation where they would be used afterwards. And then in terms of the sequence, there's certainly no rationale for one versus the other. I think often the choice has to be made based upon the toxicities that the patient, or the side effects that the patient's likely to experience. So I certainly see less neuropathy in the CLL patients with thalidomide, but we still see a lot of cytopenias with lenalidomide. So
Yeah.
for that reason, I often use thalidomide.
Yeah, we have actually published at least an abstract form alternating between the thal and the lenalidomide to try to negate the overall impact of the toxicity. So that's great. So now let me get back to Toma. I want to make sure he stays awake.
Yes.
When do you treat a patient with smoldering myeloma, or do you treat a patient with smoldering myeloma? And what about the new criteria that are being developed?
So, the paper that was published by the Spanish group late last year really turned smoldering myeloma management on its head, and that they showed a survival benefit for using lenalidomide and dexamethasone for high-risk smoldering myeloma, as defined by having an M protein greater than 3 grams and greater than 10% plasma cells. There are a lot of criticisms of that paper, and in fact, the major one is that they were actually treating early myeloma and not smoldering myeloma. The new definition, which should be coming out, I believe, next week or the week after by the AMWG, is that any patient with greater than 60% plasmacytosis in the bone marrow should be treated for active myeloma, regardless of CRAB criteria presence or not. In our clinic, we have started treating active disease such as high-risk smoldering myeloma, and not just us. Dana-Farber, Mayo are also kind of following the Spanish lead as well, with caution.
So when you say high risk, is it strictly 60% plasma cells in the bone marrow? Are there any other criterion that you would use to start therapy early? What about FISH results or genetic results? Would they compel you to use treatment early, or would you still just use standard morphologic findings or protein findings?
So it's interesting that cytogenetic abnormalities have never been shown to confer a risk in smoldering myeloma, nor MGUS for that matter. And they occur all the time. You know, one thing that we look at is rate of change in the M protein. Certainly if there's a short doubling time for the M protein, that would be of concern. And at Cornell, we love to use PET scans, and a PET scan will usually give you an excuse to start treating a patient with smoldering myeloma. If somebody has a smoldering myeloma panel, a negative PET scan, and a relatively stable M protein over a period of months, then that's the sort of patient we feel comfortable just watching.
Even if this patient had 60% plasma cells?
No, that would be somebody that we would treat.
Yeah. And with that in mind, one of the problems we have when we say CRAB criterion, we are talking about bone changes, and almost all of these patients will have a form of osteoporosis, and especially a woman of, let's say, European ancestry who tends to be slight may get osteoporosis regardless. So, but yet, if you do bone x-rays, you really have to have a lot of demineralization first to show up as osteoporosis, and it's not so very sensitive in terms of picking up lytic lesions. Are you willing to use bone marrow criterion, PET scan criterion? Are you willing to use MRI criterion for when to start your therapy? If you see, let's say you see changes on the MRI, which is very sensitive, and there are data to support this, yet you don't see much change on the PET scan or on bone survey. I think bone surveys are passé now, that at a minimum you should do a PET. That's my personal bias. Mm-hmm. But let's say the PET's negative, because sometimes some myelomas don't pick up the PET, mm-hmm. yet it shows up on the MRI that you see myeloma on an MRI scan. Mm-hmm. Would you treat the patient on the basis of the MRI?
We really don't. A lot of MRIs performed in smoldering myelomas will have this salt and pepper pattern of heterogeneity. So MRI in of itself does not really guide treatment decisions. You're very right that PET scan is frequently negative. A PET scan can be negative, and we view that as the most sensitive sort of disease marker. But for a few patients with rip-roaring active disease, the PETs won't light up.
Right.
So to be honest with you, it's more of a gestalt sort of thing.
Okay. And Rick, getting back to you, do you use alemtuzumab at all on your P53 abnormalities? Or when do you use them? Do you, and if so, when?
So I've very rarely used alemtuzumab. It's been, even though it's been taken off the market, it is still available through a compassionate use program that's very easy to utilize. And I've primarily reserved it for patients who are 17p deleted, who've got incredible marrow infiltration, who really have been refractory to other therapies. So I've only had a handful of patients this past year who I've utilized it for.
Okay, are there any questions from the audience at all? If not, I'm going to ask them a couple of more questions. I hope these questions that I'm asking are relevant to your practice of hematology.
I guess more of a comment than a question. We've talked about a lot of the newer agents that aren't approved, these indications. I realize the data is overwhelming. I don't know how much time you spend on the phone trying to get PET scans approved for myeloma and these other drugs approved. It's not very easy for the rest of us out there, and I know that the academic center is really smoothly. And we've learned with Rituxan, Dr. Call's article just came out, maybe just 4 doses of Rituxan is all we need for the lymphoma. So, it seems that the history of oncology is we overtreat, now we try to move backwards. It seems like we're going the wrong direction a little bit. I can't see giving a Bruton for CLL forever. There's got to be a better way to do it. I don't know if the trials are being designed that way.
So let me sort of address that question if I may. I didn't mean to cut you off. Was there more to ask? So we are doing a discontinuation, not we are, but there is a discontinuation trial being done in England by Peter Hillman, where they're randomizing patients between FCR and IR, ibrutinib Rituxan, with the idea that, of course, we're going to answer up front whether or not ibrutinib is as good as FCR. And I do think that's sort of a moot question. But what they're going to look at also later on is that when patients achieve MRD negativity for three subsequent visits, so it would really be over the course of 6 months, that they're going to actually discontinue the ibrutinib and see what happens. So we will one day have that information, but you are talking about information that won't be available for probably about 4 to 8 years. The ultimate question that we're confronted with is, as a physician, you have a patient with a lethal disease who's having an excellent response to a well-tolerated agent. Until we're giving guidance outside of the medical field, it's sort of hard for us to discontinue therapy. And so I've had patients on ibrutinib now approaching 5 years who really have, those patients were the ones who really were at death's door when they started it. And so the last thing that they could envision doing is discontinuing the drug.
Well, I think we all feel the same way. It's just, like $10,000 a month, I think.
Brutonab is roughly, that's correct, it's about $120,000 a year. Very few people end up paying that amount. What kind of deal they do with the insurance companies, I don't know. And the insurance companies will play the FDA indications for all it's worth, and know that the academic centers don't have any easier time of trying to get approval to use these drugs than anybody else. I'm perhaps a little bit more conservative. There are instances where I have low-grade lymphoma, and this may sound iconoclastic. I have low-grade lymphomas and some CLLs that I will just treat with Rituxan and get a very good response and be happy with, and maybe even maintain them. But even rituximab by itself is not a free ride. If you use Rituxan on a continuous basis, maintenance, if you will, almost invariably these patients will get a depression of one of their immunoglobulin levels. It's either IgM, IgG, or IgA. And what happens is these patients will then sometimes get chronic sinusitis, which will not clear. This is both applicable to lymphoma as well as CLL. Then you have to give these patients gamma globulin. And although it's more anecdotal than I have basis for it, sometimes it requires as much as 50 grams because you may want to get their immunoglobulin level up. And 50 grams of gamma globulin on a monthly basis is extraordinarily expensive. I mean, it's in there with the league with the Brutonib, and
It's more than the ibrutinib.
it is more than the Brutonib, and it's actually more than adalimumab as well, which I understand on an annual basis will cost about $80,000. And when they tell me this, and they tell me with great pride that people who make adalimumab tell me with great pride that we're much cheaper than Brutonib, I tell them it reminds me of the story of the clergyman having a funeral for a man who was not very well liked and was not very nice, and he asked the audience, can anyone say anything nice about this gentleman? A man raises his hand and said, well, he wasn't as bad as his brother. Well, they're saying this is not as expensive as the Brutonib, but it's certainly not cheap either. But it's very clear that these drugs have made a major impact on how we treat not only CLL but low-grade lymphomas, and we're even incorporating ibrutinib at this point in ABC large cell lymphomas in an experimental protocol in combination with an IMiD because they seem to hit alternate pathways. The mighty 88 pathway can be inhibited by the IMiDs, and ibrutinib interferes with the BTK pathway, and this protocol has been pushed forward by a fellow by the name of Stout, Dr. Stout at the National Cancer Institute. He was amongst the first to describe ABC versus GCB or non-GCB, however you want to define it. So like I said, I take a somewhat more conservative approach, but if any of you have used these singly inhibitors, they just are amazingly effective. You'll see the node shrink within weeks. My understanding, Rick, is that if you stay on the ibrutinib or adalimumab longer, the response may still be even more profound with longer duration.
So I think the ultimate issue, as I mentioned, is that these responses evolve over time. And so, the number of patients who are converting from standard disease, stable disease to PRs and then PRs to CRs at intervals of 18 months and 36 months is happening. I have 3 patients now who've achieved a CR in the order of about 36 to 40 months. So with time, these responses continue to get better. And I think from my perspective, the most important question is what are the long-term side effects of patients being on these treatments? And we clearly know what it is for FCR. And certainly, as I mentioned, MDS AML is certainly the end from our perspective for our patients. With these agents, we do have data, though it's short term, looking at infections during the second 6 months of treatment compared to the first 6 months using a landmark analysis. And we do see infections diminish, really suggesting that with treating the CLL, controlling the disease, the immune system does get better. And so it does offer, at least the safety that we need to support using these agents long term.
So, Rick, let's talk about the mechanism behind the lymphocytosis you see with these signaling inhibitors. In both instances, that is with adalimumab and with the ibrutinib, you see this lymphocytosis, which they attribute to interference with CXCR4 and the homing mechanism. But in a very simplistic manner, if you look at the diagrams of CXCR4, they seem to be downstream of the impact of these agents. What do you think is really going on to create this lymphocytosis?
No, I really do think it's CXCR4 mediated. And I think that the, BTK is actually a very important conductor of CXCR4 signaling. And it's through either CXCR4 or other adhesion molecules that we see this lymphocytosis. But I think it very well may be that it's through CXCR4 pathway interruption that we're actually seeing the therapeutic benefit as well.
That they're not able to get to the nurse cells.
But it's certainly, not just the B-cell. I mean, we call them B-cell receptor antagonists, but they're really much, much more. And I certainly don't think that interrupting the B-cell receptor is all that's necessary to get these effects.
So, being a country doctor and looking at things simplistically, if you have the Brutons tyrosine kinase congenital abnormality, you get hypogammaglobulinemia. Why don't we get hypogamma with ibrutinib?
So I don't know.
And I suspect that ibrutinib has multiple effects other than just on those cells. I contend that they have an impact on nurse cells, but that's yet to be proven. Now, when I ask both of you...
I do want to just a follow-up to that, is we do know that, BTK certainly in B cells, the only phenotype we see in these kids with X-linked agammaglobulinemia is defective B cell. What we see an absence of B cells and defective immunodeficiency resulting from the absence of the B cells. And these patients are very sick. Now, our patients aren't sick, and that's a question that's very important, obviously, because the last thing we want to do is to make our patients like X-linked agammaglobulinemia patients. And I think a lot of that has to do with the fact that our patients are, having their B cells depleted after they've had, 20, 30, 50 years of time for their immune system to develop a repertoire of antibodies, as compared to the kids who from day one have no B cells. But I think, too, is, there certainly are a lot of other... So the kids have no other phenotype. And it's interesting, they don't bleed, they don't bruise, they don't have atrial fibrillation, and they don't get diarrhea. So when ibrutinib has these side effects, it's going to be important to discern whether or not they're mediated through BTK or through other off-target effects. And I think what we're going to find is that some of the, in some cells, BTK can be compensated for through TEC kinase and other kinases that are also knocked out by ibrutinib. And so I think there was a tremendous amount that we're learning about the immune system since we've had ibrutinib to test.
Now I'm going to ask both of you about Karti, which is a hot new subject. Tomer, where do you think Karti will fit in the schema of treating myeloma patients? Will it replace allogeneic transplants? Will it one day replace even auto transplants? What do you think?
Well, I think that it's a bit more advanced in CLL than it is in myeloma.
Right.
Right now, the Karti therapy that we're looking at is primarily in preventing CMV infections, people getting allogeneic stem cell transplant. I do believe that the cure for myeloma will come through some sort of therapy like Karti therapy. Right now, what we're doing is developing agents that help our patients tread water and don't represent a true cure.
Right. With that in mind, we now have a number of multiple antibodies coming downstream. Which one do you have a preference on which one you think will be the most effective, or what sort of opinion do you have about when to use one or when to use the other? As you know, only one of them has ever been shown effective by itself.
That's correct. So what Dr. Coleman is alluding to is daratumumab, which is anti-CD38, has single agent activity. So in the phase 1 study of daratumumab at a dose of 16 milligrams per kilogram, there was approximately 35% overall response rate in a patient population that had relapse and progressive disease after 4 prior lines of therapy. This is the highest single agent response rate seen ever in this sort of myeloma population. So right now, it did get breakthrough drug status for relapsed refractory myeloma, and there are phase 3 studies going on right now. So of the antibodies coming up, we are most excited about daratumumab. Not only as a single agent, but it seems like it may play well with others like lenalidomide and bortezomib. The story is a little bit different for elotuzumab. Elotuzumab is an anti-CS1 or SLAM7 antibody that has efficacy but appears to pair better with the IMiDs as opposed to the proteasome inhibitors, and has no single agent activity. So, one could really look at elotuzumab as a sort of adjunctive therapy to an IMiD, whereas daratumumab appears to be able to stand on its own. One thing that concerns me about daratumumab is CD38 is not only expressed in myeloma cells, it's expressed in a wide variety of tissues, including stem cells. And so nobody really knows what the long-term potential toxicity could be. Also, CD38 is expressed in smooth muscle cells. And again, there have been instances of severe bronchospasm with giving daratumumab, whereas elotuzumab has been better tolerated. But on the whole, we are more excited about daratumumab and other anti-CD38 antibody therapies.
Again, it may become a matter of selecting the patient based on comorbidities.
Sure.
Well, Rick, tell me about your opinion on CAR-T and its role in chronic lymphatic leukemia.
I think it's a very interesting therapy. I don't think it really has its day yet. I think the advent of these kinase inhibitors, which are easy to give, which are safer to give, and are less expensive than CAR T-cell therapies, really have much more use for our CLL patients. It's important to remember that the response rates for CAR-19 T-cell therapies are only about 50%. They do have a few very serious adverse events associated with them. And once a patient does respond, they're B-cell depleted for the rest of their life. And it's certainly the potential for long-term consequences are real. Now, I think there was a tremendous amount of excitement because 2 out of the first 3 did very well, but no one's heard about the next 20. And that's what I think is the $64,000 question.
Yeah, they do get a cytokine storm, which can be fatal if not handled promptly. And as far as the B-cell depletion is concerned, my understanding is that these CAR T cells ultimately diminish, but that the gamma globulin depression remains for an extended period of time. But
they only diminish because their stimulus has disappeared and they're no longer there. If you were to re-stimulate them with an infusion, they would actually return. So they diminish in number, but we never see any return of B cells.
It's interesting phenomenon. Are there any questions? Does anyone have any questions about lymphoma, which I'm happy to answer, or if you wish? There's several interesting hot topics on in lymphoma now that I thought I might mention. One of them, of course, is the double hit phenomenon, how to treat them, because they have such a poor prognosis that we're really sort of in a bind on how to make them better. If you look at the survival of these patients, it's rather horrendous, and they're usually associated with poor prognostic features, CNS involvement, high LDH, whatever have you. And we really don't know how to treat them. I've personally been using EPOCH-R, and there are some retrospective data to suggest that it may be a little bit better, but we really have a long way to go in treating these patients. Several other controversial items, of course, is the role of transplantation in mantle cell lymphoma. There are some data to suggest that perhaps transplant, if you do it the first time around, rather than after the patient has relapsed, that there is a survival advantage. Some of us are a little bit doubtful since we feel that this may be an element of patient selection. And if you look at the auto transplants, they still tend to relapse, perhaps at a somewhat slower rate than those patients who didn't get a transplant, but they don't seem still to be curative. And one of the other issues is whether to use rituximab maintenance in these patients. There is one study that would suggest that there is some merit in it, and I personally do this, and again, anecdotally think that there is some benefit. But again, it hasn't been proven at all.
What schedule do you use?
I'm sorry?
What schedule of rituximab do you use?
What I use, and again, don't ask me to give you hard data for it, but if they go into remission, I keep them on rituximab 4 doses once a year. And the reason I do this is if you look at the impact of rituximab, usually it's ameliorated by the 9th month. So I try to give them a few months on where they can obtain, if you would call it, body homeostasis. And I must say that thus far, I have yet to see a relapse in these patients. But nevertheless, the numbers are small, and I cannot, in fact, say that it is of benefit, with the exception of that one study from Europe. So that's probably a controversial matter that still needs to be resolved. And whether everybody should get transplanted, I don't know. And of course, in follicular lymphoma, the issues are now coming up again of whether to use the signaling inhibitors early on. My biggest disappointment is that one of the drugs, radioimmunoconjugates, there were 2 of them on the market. One was Bexar and the other one was Zevalin, are not being used very widely in lymphoma therapy. And I think of them as very powerful agents that are very effective in follicular lymphoma in particular. One of the reasons for it is it's a bit complicated to give. You have to usually use someone in nuclear medicine. You got to coordinate things. And there have been results that we've published actually showing that if you follow these patients long enough, the incidence of myelodysplasia continues to go up, particularly in patients who were heavily pretreated. Nevertheless, if you're in complete remission at 5 years after having received one of these conjugates, you may not relapse at all with follow-up as far as 20 years. In patients who, by the way, had been heavily pretreated. One of the reasons that these radioimmunoconjugates have not been used, there was a study looking at chemotherapy plus rituximab versus chemotherapy plus rituximab, and then rituximab maintenance versus the radioimmunoconjugate, and they couldn't show any benefit. But I think that's the wrong place to use them. I think if you want to use them, you should use them up front. The treatment's very simple, and it's completed in a couple of weeks. It's hard to beat that. But I think the safest and most effective way to use it is early on. Don't wait till they've had 6 manner of treatment, and then you're going to certainly encounter some myelodysplasia. Some people contend that it's no different than giving another course of chemo, but I'm not sure that that's correct. And again, the role of EPOCH-R still remains controversial. It hasn't been fully proven. EPOCH-R has now been looked into by the Alliance, which was CALGB, EPOCH-R versus CHOP-R. It'll be interesting to see how the data evolve. Most of the studies from the NCI have been very positive, but nevertheless, it still has to show its true worth in randomized studies, which I hope will be out by next year. It is more complicated to give. It does have certain advantages, and one of the advantages is that you're giving the adriamycin by infusion, which tends to have less cardiac toxicity associated with it. It seems to be that peak levels of the ADRA is really what creates cardiac toxicity, although even when we're giving it in CHOP, we're giving it in doses that are below the usual level where you run into heart problems. Are there any other questions that we can answer? Anything at all? Well, there are not very many of you, and I hope we've worn you out. It's been a full hour, and I thank you few folks who are not inhibited by the rain for coming and attending. Thank you very much.
Thank you.